Thanks for the introduction, ma'am. A very good afternoon to the panel, the fellow speakers, and the audience. So mine is going to be a very opposite talk. It's going to be a very basic talk, which is going to basically act like a guide to the general ophthalmologist as to what to do when they see a shiny reflex in the macula. So there can be many causes for a shiny reflex, but we are going to focus on something like what this is. So that's an epiretinal membrane. So basically, what is an epiretinal membrane? It's a fibrocellular proliferation at the retinal surface. It causes distortion of the macula on contraction. There are many causes, but the most common one is an idiopathic with a 7 to 12% prevalence. There can be other causes can be iatrogenic, which is a cataract vitrectomy surgery or even a laser cryo, retinal vascular diseases, uveitis, retinal tears, associated with VMT, pathological myopia, trauma, tumors, ARMD, and even retinal dystrophies. The basic pathology is it consists of two layers. The light pink layer is the outer non-cellular layer, which sits on the ileum and is composed of non-cellular extracellular matrix proteins. The inner cellular layer sits on the ECM, and it mainly comprises of three types of epiretinal cells, which is comes from the retina, retinal glial cells, vitreous hyocytes, and the RP cells. These cells further transdifferentiate into myofibroblasts and cause ERM contractions. Pathogenesis, there are basically three theories. One is the classical theory, which says there's ileum defects and the retinal glial cells migrate to form these ERMs. The second one is the most accepted theory, which is an anomalous PVD theory. Residual hyocytes in the cortical vitreous remnants form the ileum after going metaplasia. And the third theory is just to explain the presence of RP cells in the ERM, which says that there's transdifferentiation and migration of RP cells through the retina and the ileum defects to form the ERM. Clinical features can be anything from a routine examination. Patient can be asymptomatic. It can be picked up on a routine examination. They can be reduced vision, metamorphopsia, or loss of central vision and scotomas, like seen in these pictures. Diagnosis is basically a combination of a clinical examination and one examination, which is the OCT, investigation, which is the OCT. On examination, you can see a shiny reflex, shiny membrane on the macula, absence of foveal reflex, a PVD can be present, retinal folds, ileum folds can be seen, and retinal vessel tortuosity or straightening can be seen. OCT is a gold standard investigation, and it shows the ERM as it is. The further that can show various different features, which I'll come to later. Grading of ERM is important because we need to grade them to basically understand when we need to touch them. So it can be a clinical grading or an OCT grading. Clinical grading is basically a grade 0, which is a cellophane maculopathy. It's an early membrane, transparent membrane. There's no distortion of the retina. Grade 1 is a crinkled cellophane maculopathy. It's an intermediate stage translucent ERM on contraction. It causes disruption of the inner retinal layers. And grade 2, there's a pre-macular fibrosis. The ERM becomes thick, opaque, and causes full thickness retinal distortion. And the last picture, you can see a pseudo-hole formation. In OCT grading, this is what we follow, and this is more important. Stage 1 is a foveal pit is present and there's a well-defined retinal layers. Stage 2 is foveal pit is absent and well-defined retinal layers are there. And stage 3 and 4 are ones which are important because this is when we need to operate these patients. The foveal pit is absent. There is present of something called an IFIL, or a continuous ectopic inner foveal layer. This is a hyperdense layer in the foveal region. Foveal pit is absent in the stage 4, and there is an IFIL, and retinal layers are also disrupted. Investigations, OCT is the single most useful test to diagnose an idiopathic ERM. Honestly, there is no other investigation that is required to plan management of these ERMs. Role of angiography is only to see a secondary cause. Retinal vascular diseases can be there, and underlying vasculitis can be there, vascular tumors can be there, and also to see the reduction or disappearance of foveolovascular zone in order to prognosticate the case. Other investigations such as multifocal, multicolor imaging, autofluorescence, microperimetry, and MFERG are mainly used for research and prognostication purposes. Management is basically observation and watchful waiting till the time the patient is asymptomatic. Vitropharmacolysis with ocriplasmin has been tried, but it takes care of the VMT, not the ERM itself. So definitive treatment is the surgical removal, and the MIVS era, our threshold is reducing when it comes to grading. And the important part is when we need to operate these patients. We need to operate these patients when they are clinically symptomatic. They start it starts affecting their daily activity. And also an OCT correlation is important. Like I said, grade 3 and 4 are the ones. Features here would be an opaque ERM or maybe a loss of foveal contour. Ellipsoid zone disruption is a very important sign, increased foveal thickness, etc. Timing is also important because longer the duration of visual symptoms and OCT signs, the poorer the visual recovery. Surgery is, the aim is to remove the ERM and release the retinal traction. Epiretinal membrane peeling can be done. I prefer to do a double peel, which is ERM plus ILM, because it reduces the risk of recurrence. A phaco-vitrectomy is preferred if the patient has cataract as well, because it saves the patient a surgery. Visual improvement occurs up to almost 3 years. So counseling is important. These are some of the cases that have been operated. The first one is a thin ERM in a silicone oil filled eye. The second and the third are VMT related epiretinal membranes. And these last two images are diabetic related ERMs. So take home message would be the simplest test to pick an ERM is look for an absence of foveal reflex along with a shiny macular membrane. OCT, if available, is the gold standard for picking up these ERMs. If ERM is diagnosed before taking up the patient for a cataract surgery, a VEER opinion is must before and even after cataract surgery. Counsel the patients accordingly, as the patient might start appreciating macular symptoms like metamorphopsia and scotomas even more after cataract surgery. Prefer to do a phaco-vitrectomy along with a VEER surgeon, saves the patient a second surgery. So last but not least, this is just a 1-minute video showing a couple of cases in which different approaches have been applied to take care of an epiretinal membrane. In the first case, I take out the ERM and then I realize there's a very unhealthy and a folded ILM underneath, so I go for the ILM after that. And in the second case, there's a thick pucker, so I go straight for the ILM away from the pucker and start peeling the ILM. And slowly this epiretinal membrane, the pucker, comes off along with the ILM peeling. Here, I restain just one more time to see where the ILM edge is. And then you see that the ILM edge is there. And slowly and steadily going around the macula circumferentially, the epiretinal membrane slowly comes off. Basically, pinching again and again and pulling a little bit loosens the membrane, and you should be very patient doing this. With that, thank you.
Okay, very nice presentation, Dr. Veer. So only thing that most important is to understand when to go in for a surgical intervention. So once you see the grayish membrane, you diagnose it that it's an epiretinal membrane. Not only because of the fundus examination, patient symptoms. Another thing which is becoming very common is that OCT is done as a routine for a lot of patients before cataract. And once you do that, you see a thick membrane or a little taut membrane on the macula and you decide there is ERM, so it needs surgery. So it is not like that. So until unless the patient is really symptomatic, having complaints of metamorphopsia, you see the visual acuity, then you take a call whether really the membrane needs to be removed or not. Sometimes a shiny reflex on the macula can stay for years together and patient may not need membrane removal at all.
The other causes for shiny reflex again is heredomacular degeneration can be there, or even perifoveal telangiectasia can have a shiny appearance at the perifoveal area.
It was actually very difficult to actually cover everything, so I mentioned the causes and then I focused on epiretinal membrane.
And even ischemia also, like sometimes macular, you rightly said that go for an angiography if you are suspecting a secondary ERM. So especially your vision loss and structure on OCT should commensurate.
Yeah.
If it is not, then you should better investigate more.
Yes.
Also, sometimes you do an angiography and you see leakage and you start thinking whether it's an ERM or it's a choroidal neovascular membrane. Sometimes because of the distortion, you will have leakage in ERM also. So that let that not confuse you.